नमस्कार बानंबर सर नमस्कार सर अनम्यूट सर करंदो सर अनम्यूट करंदो म्यूट हो जाइछन सर सर अनम्यूट करंदो सर ओ अनम्यूट करू होई पन्नी मो करू सर मो करूची जंगो पोस्ट कर परिबा हां टू अनम्यूट
हाँ हेला करेक्ट
सर
राइट
एटा 80 सर ओडिसा
केतबळे करबा 340
सर इमीडिएटली विल स्टार्ट एक्चुअली टिके देरी हो जाइछि केना से गोटे डीएम मीटिंग रो मीटिंग थिला
हां हां
we are connected regarding the जो vaccination of 18 to 45 44
हां ठीक है
एबे सर संगे संगे आरंभ कर देबा
हां हां
मैडम विल जॉइन इमीडिएटली मने पके दो
सर बीटाल मीटिंग नहीं होला बीटाल फैमिली मीटिंग नहीं होला
से जो ये शेयर कर दीजिए स्क्रीन शेयरिंग अच्छी এটা তো আজটা दूसरा कर दो फर्स्ट सॉरी Good afternoon, everyone. Welcome to the COVID-19 state grand rounds by Department of Health and Family Welfare, Government of Odisha, Bhubaneswar. You know, the second wave is around, and we are working day and night to save lives. And amongst this work, it's a little effort of the Department of Health and Family Welfare to enhance your knowledge, enhance your understanding. And I'm very happy that all of you are taking your time to attend the grand rounds. Last time in our black fungus discussion, we had a huge gathering and interaction. And we'll continue the case presentations, we'll continue the newer issues, and also we'll take up your questions to just face this situation scientifically by all of us. Our DMT sir has sent his message to start the program because he is in another meeting, review meeting of COVID-19. And good that we have Professor Banambar Rai, who has joined with us this afternoon as the guest chairpersons and the faculty to moderate the cases. We have two very interesting uh, case presentations by Dr. Sharmili Sinha, who is head of intensive care unit of AIMS Bhubaneswar, and also she is the uh, pillar of critical care services and association known as Indian Society of Critical Care Medicine, which uh, has started operating at cities like Bhubaneswar, Cuttack, and also Odisha state. So we are updating the knowledge. So we have Dr. Shinna who will be presenting you regarding the management, the case-based issues, and followed by Dr. Manas Naik, who is now in charge of the Oswini COVID Hospital, Cuttack, who is managing many cases. Last first wave, he was at Aditya Ashwini Bhubaneswar, managing the cases there very successfully, and he has been given the responsibility of Ashwini Katak this year, who is part of decision making in many management of many VIP cases as well as COVID hospitals. And Dr. Manas Nayak and Dr. Sharmili Sinha are the faculties for today. And our chairpersons, along with the SCB team of Nivedita Pani and Amar Patnaik, Professor Banambar Rai joined us, who is a past member executive committee of Indian Society of Critical Care Medicine, and he has been a office bearer, a leader, critical care leader of the country, and he has worked all throughout, starting from Bihar. He was in Tata Main Hospital, Jamshedpur, then Apollo Bhubaneswar, then at present stationed at Sham and IMS Bhubaneswar as critical care head and also manages ICU patients at some ultimate. So we have Professor Rai with us. Professor M.R. Patnaik is head of pulmonary medicine SCB. Professor Nivedita Pani is head of anesthesia SCB. And with all the good wishes of our dean and superintendent, Professor Datteswar Hota and Professor Lucy Das, we are starting the program. DMT sir has given a nod, and we'll start with the case presentation by Dr. Sharmili Sinha. Before that, few housekeeping announcement. First, we have already issued the pro forma to report the cases of black fungus from your center. It's available in the website of Department of Health and Family Welfare. I'm also circulating in our WhatsApp groups of COVID-19 training and hospitals. Any patient is suspicious of black fungus presenting with headache, swelling of one side eye and nose with the blackish secretions, drooping of the eyelid or ptosis, along with other features like cough, breathlessness, diarrhea, black patches in the skin, face, which can be a rhinocerebral or pulmonary or GI or cutaneous or disseminated black fungus or mucormycosis. You have to report, and because it has been declared as a notifiable disease, and then if you require any assistance in managing the case, starting from the antifungals to investigations like biopsy and different stainings, you can take help of SCB Medical College. It has been declared as nodal center for detection and management of black fungus. Next important announcement, which our MD NHM ma'am has passed on to us. There are a few dedicated COVID hospitals which are not very well training their staff in different issues of sepsis and infection prevention control. We have received complaint from different patients and their family regarding infection prevention control in dedicated COVID hospitals. So all the COVID hospitals are requested just to teach in IPC very well. The slides are available in our website. We are also rolling out the infection prevention control. Like to give example, if you are touching the door handle or a tabletop without sanitizing the hand, going and touching the patient, going and touching the medicines, can transmit the infection and can make the situation worse. So every step we have to be careful regarding our behavior or attitude, and then that is very important. And maintaining the mask, maintaining the sanitation, maintaining the distancing, and also the green zone and a red zone in the different COVID hospitals are equally important. So all the dedicated COVID hospitals, dedicated COVID hospital centers, and COVID care centers are asked to maintain these policies and to teach infection control to all the staff very well. Those who are working can follow the non-touch technique and sanitize their hand frequently, maintain the social distancing, wear masks properly while handling the patients, and then the medications and the different procedures. And next thing, anything notifiable or any difficulty, you can take the help of capacity building team. Our slides and our instructions and our guidelines are all loaded in the Health and Family Welfare website. You can download and teach your staff. And anything, any issue in particular, you can send mail to a dedicated mail ID of critical care training, health and family welfare at the rate gmail.com. So thank you all. With this, I invite the faculties of today, Professor Banambar Rai, Professor M.R. Patnaik, and Professor Nivedita Pani. And I request Professor Banambar Rai to speak few words about the present scenario and also the second wave and management before we go to the case proper. Professor Banambar Rai. Banambar sir.
Yeah.
Sir, sir, introduction from your end before we go to the case, sir.
No. This is these two cases are basically what, mucormycosis or any other?
No, sir. They are COVID cases.
No, COVID cases.
Moderate to
Okay.
severe COVID
Okay.
cases. And
Okay.
yeah, you will be. You are the expert for the case discussion, and
Okay.
very soon we'll be starting just after your introduction.
Fine. Well, thank you, Jayanta, for inviting me to this excellent forum. We have had shared views, I think, in the past, and unfortunately, we discontinued in between. I think because along with the government policies and all that, I think we did hold up these sessions in between. but it is very nice to have these sessions once again, and something which we must continue for quite some time indefinitely. In fact, now this time we have become wiser, and we must actually do this. And this is an excellent forum where we invite practitioners to share their experiences, and then we discuss it out and come to a kind of conclusion as to what we should have done or we should be doing. And something which we know that COVID-19 still hasn't got a definitive antiviral modality. And but over the last 1.5 years almost now, I think we have certainly understood what basic things that we should be doing to save our patients. This particular surge has certainly given us enough of jitters and a lot of complications which we never saw in the first surge. First surge was very demanding, but this is much more demanding. And we see that now most of our patients are actually in the younger age group. So younger age group, to lose patients, I think it is very heartbreaking, and we should do everything possible under our command to prevent this kind of fatalities, and of course to treat these complications to the fullest extent. It is very heartening to see that all over our state we have now understood, and we are also practicing to a great extent. Agreed that Bhubaneswar, Cuttack have certainly taken the lead, but I think the other places also we see they are doing reasonably well under the circumstances. It is not that every patient has to be shifted to Cuttack Bhubaneswar, but we should actually be in a position to treat patients at all the peripheral places as well. If we take the initiative, we can actually do it. Uh, Dr. Sarmili and Manas, I think both of them, I'm sure, will be having just the starting of cases, and that would stimulate the discussion. And all of us should participate in the discussion and come and join in the decision making process. All of you are doing an excellent job. That we see when patient comes from outside, we see that all the necessary treatment modalities have been initiated. I think that's quite great. So therefore, nothing to feel bad, nothing to feel that we are deficient, but we should always be discussing, and we should be coming to a consensus to benefit our patients as we go back from these sessions. Thank you, Jayanta, for giving me this opportunity, and we invite Dr. Sarmili to present her case.
Thank you, sir, for those nice words of wisdom. Actually, we are continuing till December all the webinars, as you rightly told, and there was good discussion, inputs, and learning experience at this end. But with the decrease in case number in the first wave, we just slowed down, and that's what we are suffering now, and we are jumping with the cases. We'll continue this with all your wisdom, and good that more than the numbers who are present, people are watching in the YouTube, and thousands viewers are benefited with the clinical content of this grand rounds that we have seen over yesteryears. Dr. Manas, you are here. Dr. Manas Naik, I think he'll be joining. We welcome Dr. Sharmili. She is the first presenter today. But before that, a pleasant experience to invite our additional DMT chair, Professor Brajakishore Das, to say a few words about the webinar, and we'll go forward. Professor Das. Braja sir. Actually, there was a meeting where DMT chair and additional DMT all were busy. So that's why we thought of starting. Anyway, Shamili ma'am, you can share your slides. Actually, just to say a line about Dr. Shinha, she is the in charge of critical care unit of Apollo Hospital, and she is the Indian Society of Critical Care Medicine Bhubaneswar chapter president, who coordinates all activities and planned a zonal conference. Unfortunately, for the COVID situation, we have postponed, and lot many CMEs and interactions they go on from on behalf under the leadership of Banambar Shah. We keep on updating our critical care physicians in this field, and it has a big role in managing cases during this crisis time, and this is of help, and she has been working throughout for the patient. I talked to her a few days back regarding the availability of the equipments and the instruments for the care of sick COVID patients, for which she was much concerned. And today we are very happy. We have a very active team of doctors in the critical care in the Twin City, as well as groomed in the state, who are taking care to provide necessary support to the ailing patients during this time of crisis. We present you Dr. Sharmili Sinha to discuss the management case based. I request Dr. Sinha to share her slides.
Thank you very much, Professor Dr. Jantonda and team. And Dr. It's always delighted to see Dr. Banamba Rai on board. The case presentation, it has been really quite going busy, especially in the last 6 weeks. I'll start the screen sharing. Why it's not? It's not giving the option actually.
Yeah, and you are a co-host, Dr. Sharmili. You are a co-host. So
Right.
just click on the share screen below.
Yeah, I do normally. Just give me a moment. There's something
Yeah,
is changed in the thing. Just give me a moment. I'm just stopping my video for a moment.
yeah,
I'll be back in 1 minute.
sure.
Is it visible now?
Yes, ma'am.
Okay,
It's
okay.
big.
I won't be
Yeah,
able to do
please
the full
make
screen.
it full screen.
No, no, I won't be able to do full screen. There's some issue here with the Microsoft PowerPoint. Is it okay? This much is all right.
Yeah, it's okay. But you can make a slideshow also, no?
No, no, I can, but what happens is there's something wrong with this. If the moment I make it, it might go blank again.
Okay, then fine.
Yeah, I'm not checking just dance actually. There's
Yeah,
another issue.
yeah, fine.
So I'll just share with you a recent case which was discharged on 9th of May from our hospital. She was a 71-year lady who is a known case of hypothyroid, diabetes mellitus, and oral hypoglycemic agents, couple of cardiac medicines, and also overweight, though not morbidly obese, but she was definitely on the overweight side. around 79 kgs for her height. So she had the history of shortness of breath for which lasted for 10 days. She had no history of fever, but later on we gathered she probably had low grade of fever for a few days, which was not noticed. But definitely there was no cough. There were a couple of members in the family who were COVID positive, and she was tested positive on 23rd of April. Initially, she was managed at home with home isolation. When the breathing status worsened and oxygen saturation started falling as they measured at home, went less than 90, she underwent a HRCT chest, which was done at KIMS Hospital, Bhubaneswar. There, they found a high CT severity index of 22 over 25. So thereby she got admitted there in KIMS, and in the KIMS ICU beds, she was on 12 to 13 liter of oxygen and saturating around 85%. She was quite tachypneic, work of breathing was very high, and she was barely cooperating with a BiPAP machine there in the ER. So hence in that evening she was shifted on 24th, she was shifted to Apollo. Sorry, she was shifted to Apollo on 27th. On arrival here, she was quite tachypneic and tachycardic up to the tune of 134 per minute. Obviously, these patients who are on high ventilators on oxygen requirement or BiPAP or NIV in one healthcare center, in the process of shifting, actually, most of them do get deteriorated unless they're intubated and on controlled ventilation mode. So very predictably, she deteriorated during the transport. She was even more tachypneic when she arrived here. She was tachycardic. Blood pressure was stable, but saturation was only 70% because the mask which was fitting on her face was loose, and a lot of oxygen leak happens when such hypno masks are used during transport, and she was just barely saturating 70% when she reached the emergency department. So within half an hour she was taken to the hair dependency unit. She was put on an NIV by 12 by 7 settings with 80 to 90% oxygen to start with. And around within 1 hour period of time, the saturation improved to 97%. She had a couple of electrolyte abnormalities on the blood gas. Sodium was in the lower side around 126, 127, and potassium was also on the lower side, which was gradually corrected. The standard drugs for severe COVID-19 pneumonia, because she was within the first 10 days of the positive report, and symptoms of worsening and the CT scan was also worse. We started on remdesivir, low molecular heparin. Dexamethasone was given as the chosen steroid, and insulin was used in the high dose to control her blood sugars. Now, the strategy which we adopted for her, that we insisted on awake proning. Now, she being an elderly lady and morbidly obese, it was difficult for her to be proned in the awake positions. But with a lot of counseling, we got her to do that. Initially, actually, she could manage maximum with the lateral positions, left and right lateral, alternate every second hourly. But awake proning was difficult for her in the first 48 hours. But later on, with a lot of counseling and video calls with her family, she agreed for proning positions, which actually dramatically helped her recovery. So you can see this is the initial markers when she got admitted on 29th, on 27th actually. These are the markers which were done initially, which show CRP is quite high. CRP, if you see the normal level is fine up to 10 to 12, but this is in the tune of 123, almost 10 times raised. D-dimer, this is the unit. I draw your attention to this unit. It is microgram per ml. So if you make it nanogram per ml, which is mentioned in many literatures, it can become more than 2000. And with microgram per ml unit, it is usually less than 0.5, or maximum you can take it up to 1 microgram per ml, but this is up to the tune of almost 2.5 times raised. WBC count was not raised much. So these are the X-rays that she had. This is the first X-ray. If you can see, on initial presentation, she has diffuse bilateral opacities. Only the apices are spared to some extent, but rest of the 2/3 of the lungs on both sides are quite dense, hazy. This is the X-ray after 2 to 3 days of NIV and drug therapy, and this is on 1st of May when she had actually clinically improved. We'll just come to the clinical course. So this lady, actually, we did not do anything magical. It was the classic, the drug therapy that we have been using for all the severe COVID-19 pneumonias, and the positive pressure and the awake pruning and other supportive therapies. I would like to draw your attention to the strategies, I think, which is being successful in most of the patients who are presenting at the right time to appropriate healthcare center, and if they are lucky enough to get an intensive care unit facility. So the first best thing which helped her, I would believe, that it is the early institution of the positive pressure ventilations. It can be in the form of a non-invasive ventilation. Non-invasive ventilation, we call it when we are giving this ventilation with a proper big ventilator, the classic conventional ventilator. Or if you do not have the logistics, like these days we are running short of ventilators, even you that kind of positive pressure ventilation can be instituted with you by using the conventional BiPAPs. Nowadays, this BiPAPs are of two types. One is the AVAPs, that is the assisted ventilation mode. Otherwise is the conventional, the smaller BiPAP machines or the CPAP machines, which are for decades are being used at the home level also for OSS, sleep apneic patients. So institution of positive pressure ventilation for patients who are on high oxygen requirement is actually, it's a very good and early, if it is promptly instituted, can result in reduction or amelioration of the symptoms and can drastically reduce the oxygen requirement. Awake pruning is it's a proven strategy and quite widely adopted across the globe, and it has really helped many patients when it is actually really practiced. But it requires a lot of conviction, counseling, and patient needs to be convinced for that. But whenever followed, we have always seen all these COVID-19 patients, be it severe, moderate, or mild pneumonia, whoever are requiring any oxygen therapy or otherwise dropping their saturations from less than 92. With this awake pruning, it definitely the saturation does improve. For those subset of patients who are for a variety of reasons are not being able to adopt awake pruning positions, there is definitely this option of lateral position. We go by the principle of something better than nothing, because in lateral position also, if you are doing it alternately 2 hours on both sides, it also gives an adequate chance for each side of the lung to open up their ventilations, and BQ mismatch, that is the perfusion and ventilation mismatch, gets improved. Aggressive sugar control is something I would highly emphasize on this, because most of these patients who are coming with severe COVID-19 pneumonia, we are using high dose steroids. And now, because so many therapies have come and gone and have taken a full circle, three things only remain established and well adopted with better grade of evidence are steroids, heparin, and awake pruning. So we are very sincerely and religiously follow these three protocols in all patients who are presenting with moderate to severe COVID-19 pneumonia. And for aggressive sugar control, actually, we need to monitor the sugar much more frequently. Now, just imagine for a patient whose sugar is going above 300, we have to do it almost hourly or 2 hourly to check the sugars. So for these kind of patients, they would definitely require a combination of both long and short acting insulins and infusions when required. One practical problem with the infusion and sugar monitoring is about the sampling, because a patient who is in so much discomfort with high flow mask and is on intermittently on NIV or BiPAP machines, and you're asking them to be prone or in lateral positions, if you are checking their sugars every 2 hourly, you're pricking them on the finger, they become very uncomfortable and they do not cooperate. So I would say for close monitoring for such patients who are in a setup of at least an intensive care unit or high dependency unit, it is very prudent, and it's a very wise and smart approach to have the appropriate lines. That would definitely include an arterial line, at least if we have in place. That gives a scope to the nursing staff and other paramedic staffs, even to junior doctors, to go for frequent sampling as and when required. You can do the blood gas samplings more often. Then you can draw even the samples for blood sugar monitoring. And ABG also gives us the sugar monitoring if you're doing it 4 hourly or 6 hourly for severely hypoxic patients who are on high support, either on the high flow or in the NIV or BiPAP. You can use that arterial line. Central line is also very much helpful. I have found that because these patients who are, either they would have stayed at home for a long time and then probably would have come to hospital at a delayed stage, or if they are being shifted from other healthcare centers, their peripheral lines would have been used. They might be having the swollen limbs and thrombophlebitis. So getting an access, and when you're using multiple injections, this IV access actually becomes a practical problem. So it is also very comfortable to have a central line in place. Now, which central line and which side? Because central line, we are doing mostly the three sides. That is the jugular, the subclavian, or the femoral line. Now, patients who are in quite hypoxic and the work of breathing is high, they're using their accessory muscles of breathing. It is difficult for them to do a line in the neck, be it either in the jugular line or in the subclavian line. And when they are actually inspiratory drive is more, there is a chance of pneumothorax if you're attempting the necklines. For these kind of patients, we generally propose to do the femoral central line, though it is not the most ideal place for placing a central line. But under the circumstances, for patients who are in respiratory failure, either hypoxic or or combined hypoxic plus hypercarbic respiratory failure, it is more wise to do a femoral central line, because your pneumothorax risk is obviated. And then you can always revise the line position after 5 to 7 days, or maybe up to 10 days. Also, it is a good idea to have a urine catheter for these patients, because though these patients are deceptively awake, they are in much distress. They might be looking at you, may be trying to express, and might be even, sometimes talking to their relatives over phone, but they are quite much in distress. So if they're passing urine, on their own spontaneously when they're on high therapy, be on the non-invasive ventilator or in the BiPAP, it is very uncomfortable. Every time they want to pass urine, they have to remove the mask, and that time they tend to desaturate. So it is actually a good idea to have a urine catheter for these patients, at least for a short period of time, till the patient marginally improves, and then you can review and then decide about removing the urine catheter. And this also gives the comfort for monitoring the intake output chart, because for patients who are elderly are having more comorbidities, you never know how when their urine output starts falling. And because it's not possible to do the renal function test on a daily basis, and it is also not recommended, at least you can keep a watch on the urine output for these patients. Counseling, we found, is really a hard task, but it gives really a lot of positive results. And if you go and spend during the rounds, I actually spend more time in counseling the patients, more about the proning part, because drugs, etc., everything is predefined. We are giving it anyway. But if a patient who is awake and on positive pressure ventilation, either NIV or BiPAP, or they are being asked to be prone, it is the counseling which is most important. Now it is definitely a hard task, because the medical team or the paramedics who are in the PPE wearing a double mask with a face shield, they can't see us. That eye to eye contact is not being established, but the voice is at least audible, and they are also having the mask, and with the noise, background noise in the intensive care unit, the communication also gets affected. But nevertheless, if you're making that 5 minutes effort to counsel such a patients, believe me, helps a lot. And these patients I have seen the cooperate a lot, which also materialized in this case. And this lady was shifted to ward after 9 days of stay in the HDU, that is high dependency unit, after she tested negative for the COVID RT-PCR. And at the time of shifting, she was almost on 1 liter of oxygen. So this is the X-ray again. Just share. These were the initial two X-rays, and by the time she was shifted on first, she had this. You can see there is clearing of most of the medial regions. Even the middle zone is almost clear. Only a little bit of the peripheral 1/3 is still having these opacities. And the X-ray actually, which was at the just 1 day before discharge, was almost clear. That I don't have here. So now coming to how much steroids. Steroids, I did use very high steroids in this case. Now, this, we have last 1 year, 1.5 years have been spent in many controversies, including steroids. And a lot of people have first put forth the use of methylprednisolone, hydrocortisone, dexamethasone. Now I think it is quite consensusly accepted that dexamethasone is superior to methylprednisolone, at least based on whatever evidence we have so far. And we did use a bit higher steroid for this lady, because her CRP, if you remember, it was 123. It's almost 10 times that above normal, and she was quite toxic with this kind of diffuse infiltrates. NPF ratio was almost 50 to 60. That is equates to severe ARDS. So she was given 6 milligram twice daily, and gradually it was tapered down to 4 milligram BD, and then made oral, and then completely weaned off. The price we paid was for high sugars. She needed insulin infusion quite often, But we did that because we had placed an arterial line for her, so it did not cause much trouble or discomfort for her. We were able to do it every 2 hourly, and with the titrated human actrapid infusion, we could control her sugars. And we kept on increasing the long-acting insulin also, which was an OD dose, that also really helped in controlling her sugar. And I think that is one of the most important strategies that helps the recovery from the pneumonia. And number two, also the other dreadful complication that we are not talking about now is the mucormycosis. And again, it is other thing which always looms over our head is the risk of secondary infections, because steroids of that high kind of high dose is always a double-edged sword, and we are using it to create immunomodulation, but also we are predisposing these patients to secondary infections with the central lines, arterial lines, urinary catheters, and an elderly lady with already poorly controlled diabetes mellitus. So this always exists, but I would give all the credit to the infection control practices that saved this lady from acquiring any secondary infections, though not all patients are that lucky. But the key point here is, to keep watching and keep reviewing the lines every day, be it a central line or arterial line, even a urinary catheter. Every day basis, we need to, review our patients that how early if these lines can be removed as soon as possible. Low molecular heparin, it is a preferred over the standard heparin, definitely, and all the guidelines actually now recommend low molecular heparin over standard heparin unless the patient has creatinine clearance less than 30. And we also used a little higher heparin in this case. The lady will be around 80 kgs. And the D-dimer, if you remember from the first slide, it was almost 2.5 times the normal, and with a severely hypoxic and PF ratio around 60 to 70. We decided to use a higher low molecular heparin. So it almost comes to around 1.2 milligrams per kg for her. And there were no bleeding complications that we have witnessed not only in these patients over the last 1.5 years, or most of the COVID-19 cases which we have treated in intensive care unit, we have not witnessed any cases of heparin-induced bleed in these patients. Some patients, only those patients who had only predisposing factors like pre-existing gastric ulcers or carcinoma or maybe liver disease, they had probably a couple of episodes of GI bleed which were induced or exaggerated by this use of heparins. Other than that, in my experience in the last 1.5 hours, I have not witnessed any bleeding which was solely can be attributed to use of this degree or higher doses of anticoagulation doses of heparin in these cases. And multivitamins, whereas an adjuvant therapy was given. We did not use tocilizumab in these cases, neither the plasma therapy, which is obviously outdated. So I would emphasize that what we did differently in this case is we did not do much differently in this case. It was the basic intensive care and that which we practiced, and we adhere to that. But I would say the first slide, I'd like to just one point at this juncture I would like to discuss is about how to choose ventilations. Because at this point, as we know, in the second wave, in many of the bigger states where it is already probably cross-passing the peak of the second wave, they have all been confronted with the oxygen shortage. And at this point, I would say that many patients we see are either in the main cities or in the smaller cities or even in the COVID hospitals or COVID care centers, they are on high flow oxygen. High flow oxygen is anything beyond 6 liters, up to 10 to 12 liters. And sometimes people are, the flow meter can go up to 15 liters also. If you're keeping these patients only on oxygen and a high flow mask, it causes a lot of wastage of oxygen, because the FIO to deliver to the patient may be high, maybe to the tune of 80 to 100%, but the oxygen which is lost in this process is quite a big amount, because this masks are nevertheless never tight fitting on the face, and a lot of oxygen leakage keeps happening. So when for these cases, if you can give them early institution of positive pressure ventilation, it may be a BiPAP or NIV or maybe CPAP sometimes. It does help the expanding the lungs of those collapsed alveoli and reduces the oxygen requirement. Now, how do you choose about giving NIV over CPAP? Now, work of breathing is something for a patient who is having hypoxic respiratory failure is a very important parameter to monitor. Work of breathing, we infer Suppose a patient like this lady, when she came, she was tachypneic, she was tachycardic, and she was having high work of breathing. How do we clinically assess it? Now, if you look at a patient who is is tachycardic or tachypneic, and using the accessory muscles of breathing, like there is flaring of the ala nasi, is using the sternocleidomastoid, or the chest muscles are accessory muscles are being utilized, that indicates that work of breathing is high. For these patients, if you are giving them positive pressure ventilation by either a non-invasive ventilator or a BiPAP or AVAPs, whatever is available in the in the unit, it definitely reduces the work of breathing, and thereby simultaneously, due to improvement of the VQ mismatch, also oxygen requirement does come down. Like this lady in the first 48 hours, just solely because of use of NIV and to also some extent of the positioning, oxygen requirement drastically came down to 60% and then 40%. And whenever we are doing it intermittently with the NIV plus high flow mask, she was on 4 to 6 liter of oxygen very within 4 to 6 days time. So I would emphasize on institution of positive pressure ventilation at the right time. This is not difficult. If you do not have this conventional ventilators for non-invasive ventilation, you can use the smaller BiPAPs, which are small in size. It is easily, you have just an electric point to plug it, and you can also connect it to the oxygen source while the patient is on BiPAP. And this is one of the important strategies which is being now emphasized in all levels as a oxygen saving strategy. Thank you very much. I stop sharing now.
Thank you, ma'am. Actually, it was a very eye-opening case. Usually, such type of cases we come across, which has been managed very properly. The right time, patient has received the oxygen in the right way, and all the supportive treatments which we give at the point of deterioration, starting from oxygen, the steroid, the low molecular heparin, the awake proning, and of course the antivirals were given, and the patient has recovered. The shadow shows a decrease. Did you go for a CT scan of the patient later? I don't. Uh,
She came with a CT scan which was done in KIMS already. 22 by CT CVT score was 22 by 25, and when she came to us, she was in such a hypoxic state and failure that we could not have moved her out of ICU for a CT scan. And nevertheless, it was not necessary because she had it already, couple of days ago before she came to us. Now, I would like to emphasize at this point that CT scan actually is not necessary. It does not guide management. It is the clinical status of the patient which actually guides management. Like this patient, she was having high work of breathing, oxygen requirement is high, and that's it. And accordingly, and she had some reports already imaging from outside. We had the markers also in our setup. So I think that was good enough for bundle of investigations to do the treatment. CT scan frequent, it's not necessary. And now she's discharged. Actually, I did her follow-up teleconsultation also 2 days ago. She's doing very fine. She's at home and doing her normal activities. Chest X-ray is completely cleared, as I pointed out, even before discharge. And I have asked for a CT scan actually after 3 months, because whatever remodeling happens, it goes on for a period of 3 to 6 months, even according to the literature, if you see. So, if the patient is clinically well, she does not have much, breathlessness or exhaustions during her day-to-day activities, that means she's coping up well. Now, how the lungs have evolved or how much it has recovered, that is best remains to seen after, I say, after a gap of 2 to 3 months. Because during hospitalization, I would say CT scan per se do not guide treatment. It does not have any therapeutic implications. It might have a prognostic value, but it does not guide treatment. And now for a patient who is on such high respiratory support like NIV or on high flow oxygen, I would recommend not taking these patients out of the unit for just doing a CT scan, because most of these patients are very sensitive to movement. And if taking shifting them from the bed to the trolley to the scan table and coming back, most of them deteriorate actually. So it's
yeah.
better.
Yeah, very, very rightly told, ma'am. The clinical assessment is very important. The respiratory rate and the type of respiration and the intercostal indrawing and the labored breathing all tell us that the patient needs support. rightly managed. I'd like to know the opinion of our experts. Professor Niveta Pani has joined in between. I welcome ma'am. And first, I request Professor Banambar Rai to tell his views on the case. Professor Rai.
I think Sarmili is absolutely right. We do not disturb this particular patient from the ICU bed when he is on, she is on a very high flow oxygen or non-invasive ventilation for a mere CT scan. And CT scan certainly does not become a game changer. CT scan only diagnoses, and functionally how the patient is on the basis of which you decide the therapy and interventions. CT scan certainly will not tell us as to when and what we should intervene with. This is one which I think is very clearly understood. CT scan, as she rightly said, that we generally ask for a CT scan after 3 months and to see whether the changes have disappeared or still there is fibrosis or something. Sometimes many people, pulmonologists in particular, would like to do a CT scan after about a month or so, or even 15 days once the patient is off oxygen or taking very little oxygen, just to add antifibrotics, which I do not agree. I do not agree, but this is a study which I think time only will say whether antifibrotics would actually help in these cases. In that case only whether you give whatever, but many pulmonologists are divided on this. They do not actually give, I think majority do not give antifibrotics. Some of us give. Those who are doing researches as to whether the antifibrotics work, they could perhaps do it, but only after the patient has come out of the critical stage. You could do it, and if you want to add and do a randomized control trial, you can always do it. But otherwise, for therapeutic purpose, CT scan is certainly not indicated in such cases. The other thing, Sarbili, I just wanted, because you give dexamethasone twice, 6 milligrams twice, but the recovery trial did not say twice. It actually said once. So whether you give, but 8 to 10 days, yes, the tapering, everything together should be taken off in 10 days time. But twice means it comes to about 12 milligrams in a day, which means it, if you extrapolate it with the dosage of methylprednisolone, it fits very well. 1 milligram per kilogram methylprednisolone, which means that it is 12 into 5 times, that is 60. So it fits in very well, but recovery trial did not say twice. It actually said once. And with that once dexamethasone, their results were, I think, quite suggestive that dexamethasone is a game changer. They said that because there are 2,000 odd cases, they gave dexamethasone, and 4,000 cases, they did not give dexamethasone. And the mortality in the study group was 22.7%, whereas in the control group it was 25. It is actually statistically significant, but the number is large. So therefore, 6 milligrams is what? But we give 6 milligrams a day.
Yeah,
Dexamethasone we give.
yeah. Recovery trial also use that, and it's zero point 0.1 to 0.2 milligram per kg body weight. So 6 milligram OD is enough, I think, because it's a long-acting steroid. We can give once daily, and that has better effect than the methylprednisolone or hydrocortisone because of its
Yes,
longer acting.
that part is taken well. There is absolutely no.
I agree with you, sir. The recovery trial, which came in 2020, did mention the dose that we are saying. But what I have noted in this second wave, before it started affecting Odisha, actually, we're closely following our colleagues from different states, mostly the Maharashtra, Delhi, Gujarat, those three states mainly. What we found that the inflammatory response, if you see the first wave and the second wave, obviously more patients are sicker, younger age group being affected, fever is lasting longer, and fever is also touching higher numbers like 100, 102, which was not there last time. And somehow, I mean, obviously, more biomarkers, because people know this now, they themselves go and get this biomarkers done. And more number of people are actually requiring hospitalizations, and that too, oxygen requirement. maybe even in that moderate case for a bit longer period of time. All these things, recovery trial is done in Europe and US. I mean, those kind of subsets. Our population, and with this ongoing mutations, and now probably more than 20 kind of mutants circulating in the country. I believe our genetics and our kind of mutants, it's showing a different kind of response, hyper-inflammatory response compared to the one that was witnessed last year in Europe mainly. So obviously, there is no trial to prove it. We are all using on our based on our experiences. But this second wave, after we have started using this high dose of steroids and a bit high dose of low molecular heparin also, I would say that is also a bit high compared to what we have in the literature. We have somehow found, I mean, in my experience, it cannot be extrapolated anywhere else, found better results, patient responding early to with this mixture of drugs plus some institution of early positive pressures, either in IV or if they end up in intubation, that is there. But I would say, but the at the cost given is the higher sugars. That we have to be very strict and aggressive about controlling that, and that is the basis of using this high steroids. Other than that, literature, yes, still research is going on. But I would say from other parts of the country also, what we hear from other colleagues, they're all more inclined towards using higher steroids and earlier than not compared to the first wave.
No, there are also a lot of clinicians who use, steroids, particularly methylprednisolone, 250 milligram twice a day, and they go by the CRP and IL-6 values, which also is very much criticized by most people, saying that you do not give steroids for IL-6 or CRP values. You give steroids for the inflammatory reaction in the first 10 days, not even, for cytokine storm. That is what also they would say. But many people believe that if you give a little higher steroids in cytokine excitation syndrome, it works. We're not very sure whether it really works, but yes, sometimes we also do that. The other thing, Samili, I wanted to ask you is this, that straight away you go for NIV, or there are also situations where you could actually do well with the high flow nasal cannula, or even high flow nasal oxygen without, many people don't like, the NIV suffocation, and they would be most comfortable with high flow nasal oxygen or high flow nasal cannula. High flow nasal cannula does very well. In such cases where we could avoid a non-invasive ventilation by face mask.
Hyflunazole cannula, I would say a few points. Last year in the first wave, we used hyflunazole cannula in a couple of patients. We found number one, they did not tolerate it well, and number two, the results were not good. And actually, most of them, we rather had to convert to intubations. In the second wave, from whatever is going on, I found if the worker breathing is high, as I mentioned about the if they're tachycardia and they're already using the accessory muscles of by clinical assessment, they are short of breath, and that if water breathing is high, no matter of high flow oxygen or even high flow cannula, in my experience, I do not think it helps. In that case, it is definitely the positive pressure has to be instituted either by non-invasive method or by invasive method. Now, NIV has a catch point that patient has to be cooperative. Otherwise, it won't. I mean, they will not keep the mask and you'll not get the any desirable result, or even cannot wait for that period to see. If there is leak happening, they are claustrophobic, then you probably end up intubating those cases. But if you can achieve that by rigorous counseling, which is I mentioned that it is actually during rounds I spend more time in counseling rather than looking at the drug chart, because it is more or less the bundle is fixed. We spend more time for these patients in counseling, and if they are cooperative, it is definitely helpful. And number three, about high flow cannula, I think everybody that is now, we agree in our intensivist circle that if you have to save oxygen, NIV or BiPAP is a better choice than HFNC, because if you are going in flow up to say 30 to 40 liters, even if you are giving a high airflow, some say you make the airflow high and the oxygen level low, even then also oxygen loss or leakage of oxygen, wastage of oxygen is more in HFNC compared to NIV. Because with NIV, with that kind of positive pressure, we can bring down the requirement to 50 to 60% for somebody who is on 12 to 14 liter of oxygen, compared to HFNC where you can go up, need to higher flow up to 30 to 40 liters. So these are 4 points for which you do not prefer HFNC, and we are not using in the second flow second wave anymore.
On the contrary, Sharmili, your financial aspects, I think, is very well taken, particularly when there is oxygen shortage. But we believe that, high flow nasal cannula is so well tolerated and patients are so comfortable that they are actually quite enjoying that. And when you ask them to do the proning with high flow nasal cannula, they are excellent, absolutely. But with a NIV mask, it is a little bit of a cumbersome process. Agreed that it actually consumes a lot of oxygen.
And also, if
Oxygen.
water breathing is high, HFNC also.
No, if it is no, you connect the high flow nasal cannula, the water breathing comes down. Because high flow nasal cannula, if you give 60 liters, you also get a 6 centimeter of positive end expiratory pressure. And carbon dioxide accumulation with non-invasive ventilation is quite a bit of a problem at times, which actually is obviated by the high flow nasal cannula. Actually, there is no carbon dioxide accumulation with this. In fact, it actually treats the carbon dioxide accumulation. Whatever carbon dioxide is accumulating in the faucets in the mouth cavity, it is actually washed away by the high flow that you give to the high flow nasal cannula. It is very good. In fact, we thought that in place of ventilators, we could take more high flow nasal cannulae, and that would actually, we have done that, and that has actually created a lot of comfort for the patients. But your oxygen consumption, yes, it is an issue where there is an oxygen consumption issue. Certainly. Any other comments that audience would like to interact with Dr. Sharmili?
Sir,
Excellent presentation.
Sir, Namaskar, Nivedita.
Yeah, Nivedita.
Sir, actually the problem, we don't have the high flow nasal cannula in our place. So whatever we are using with the 15 liters flow, either with the non-rebreathing valves. So when we are seeing that the non-rebreathing valve, the patient is not able to sustain, then we are putting on the NIV mask.
Absolutely, there is no choice, and NIV you should go for that.
Sir, and the problem is that, sir, once the patient in the NIV mask, we can't allow him to go to the urinals or anything. I have seen so many patients, sir, if they are little bit, we are leaving them either high flow or the NIV also, immediately they are collapsing. So my suggestion is that the catheter should be compulsory to all those patients, sir. Not a patient, they are very much hesitant to use the catheter. They are telling, no, we are all right, we are feeling okay, why should we wear the catheter? But sir, as far as our practical experience, we have seen the moment the patient is going to the bathrooms, he's falling collapse, sir. What do you say about that?
No, you should not allow these patients to go to the bathroom. I think they have got to really pass urine on the bed itself. After even they have come out of NIV or high flow nasal cannula, if they are on 2 liters oxygen also, we don't allow them to go to the bathroom. They would collapse because the moment the oxygen is off, they actually start having reeling of the head, they become breathless, and they are quite a bit of a trouble they face. So I don't allow them, even in the general ward when they are there, I don't allow them to go to the bathroom.
And sir, second thing that what you have discussed about the antifibrotic, sir. Sir, actually antifibrotic, what Sharmili says, sir, before third week, should you start the antifibrotic? This is my question, sir. I feel, sir, always it's second week, some people are using in the end of second week or third week. Sir, unless we see the condition of the lungs, we should not start before third week. This is my suggestion.
Madam,
what do you say, sir?
Nivedita, madam, sorry to interrupt you. Actually, Dr. Manas is having an emergency. You know how much of stress is on him. So because he has already joined and wants to finish up his case, we'll take both the cases discussion together at the end. Maybe he will be spared if he.
Okay, Manas could present, I think now.
So in 10-15 minutes he can finish up his presentation. Sorry for the interruption. We'll go for Dr. Manas' case. Manas, you can share your case and start presenting.
1 minute. Sure.
By the time Dr. Manas shares his screen, he is the critical care in charge of Ashwini Hospital, Cuttack at present and head of the dedicated COVID hospital. He has treated many important lives very successfully and in the state COVID management team to take a call in crucial issues. So he has successfully proved himself to be a right hand in the crisis, and many people believe his decision, critical care decision making, and he is presenting an interesting case for making all of us updated in this uh, difficult situation. Dr. Manas.
Yes, sir. Really finding difficult to share the screen.
Yeah,
One
you
minute.
have to click the share screen below.
Yes,
The
yes, sir.
green arrow below.
Yes, sir.
You come
Yes, sir.
below. Yeah. Just click the share screen, and you have to open the slide in your desktop or laptop. Uh,
First, open your presentation on the
yeah,
screen and then click on share screen.
yeah. First, you open the presentation. Don't make it full screen. Just open it in the desktop. Then click the share screen. Select the screen, and then click share. Or else you can mail it to me. I can share from this end.
Yes, sir. 1 minute. You carry on your discussion. I'm just sharing. Sir, you carry on with Nivedita Madam's discussion. I'm sharing.
Yeah,
It will
yeah,
take,
yeah,
it will
fine.
taking some time.
So,
You can carry on with your
yeah,
discussion. Just
yeah,
Manas, no problem. Sir, Banambar sir is there, sir?
yeah, ma'am.
Yes, yes,
Sir,
Nivedita.
what do you think, sir? So when should you start? Third week, or what you feel, sir?
Antifibrotics.
Yes.
I do not
Or
start.
it is, sir, or it is
I,
theoretical, sir.
Nivedita, I do not give antifibrotics, and I am not convinced that it actually works, because one of our pulmonologists, she has started, randomizing first, third, fifth, seventh cases. She would give antifibrotics, and the even numbers she would not give. I have been pestering her to tell us the results. She has not got good results, as she says. She says, "Sir, when I get the results, I will tell you." So I'm not very sure, but when we were discussing with Dr. Behra and Dr. Guleria on certain forums, both of them said that they do not start antifibrotics, and they do not have sufficient proof that antifibrotics work in these cases, because the antifibrotics have not worked in interstitial lung disease, and not very sure whether it really works in these particular fibrotic conditions. But suffice it to say that we have had 4 cases who actually were not given antifibrotics. They came after 3 months. They had 22 by 25 and 24 by 25 and 25 by 25, like that the CT changes, but all the CTs were normal after 3 months without antifibrotics. I'm not very
Yeah,
sure whether
we also have the similar experience, sir. The type of fibrosis which takes place in this post-COVID, long COVID, is not exactly same as ILD, and people have reversibility. And many of my follow-up patient of long COVID has clean chest and also clear CT scan in a period of say 12 to 24 weeks. So we initially were very reserved about the antifibrotic therapy, may it be nintedanib or perfindon, but of late, keeping few guidelines, maybe for 4 to 6 weeks, hardly it is given. Even if not given, doesn't make much difference in outcome. That is our experience.
More than 3 months, I mean, even sometimes up to 6 months also, antifibrotics have no role.
Yeah.
And as you said, viral pneumonia has always existed for decades. I mean, since time immemorial, viral pneumonias have existed. And if you look at the radiologic pictures, it always there is a radiologic lag. in recovery. So it is the functional capacity of the patient which actually tells us about the recovery. And if you have to just have a radiological, proof of parenchymal restoration, you can get it done. But within 3 months, it's certainly not recommended.
Yeah. So I think it's very well taken. Dr. Manas, are you ready with the case?
1 minute.
Or else you can mail me. I'll share. No issue. Because I understand your pressure at Ashwini. Lot many work and your wrongs are due. We don't want to do. Yeah, you can mail me, Dr. Jayant Panda at gmail.com. You have my mail ID. I'm putting also in the chat box. You can mail me. I'll share from my end. So it was a very nice presentation by Dr. Sharmili, and few points are very clear that at times you need higher doses of steroid and anticoagulant, and you have to titrate it. And what we feel that the initially not giving steroid has a wisdom because the viral load and viral count increases, but at the point of patient going to moderate stage, we can start with the low dose steroid just to check the cytokine storm, and also the antifibrotics doesn't have any promising result, but those who can afford, we can try for a short course in them. There is a lot of difference of opinion and controversy in its therapy, and for management the clinical assessment is vital. CT scan is not mandatory. Just for a CT score, we do it when patient is comfortable or patient is stable or patient is ready to be shifted for CT scan, and that also doesn't correlate very well with clinical condition, because at times we see CT score of 25 and 25 recover, and CT score of 8 by 25 they deteriorate with non-compliant lungs. So very good decisions are taken. We'll still add more findings from Professor Pani and Professor Rai, as well as Sarmili. I'll request her to stay back till Dr. Manas completes the case, and we'll go to the next case. And Dr. Manas, you have mailed me?
I sent you already the WhatsApp.
Yeah. Okay, fine. I'm doing it. I'm a mail editor. Yeah. WhatsApp Manas, Asini का WhatsApp में?
आपण डिस्कशन टे स्टार्ट करता हूं आम्हाला पर्सन करू
एटी हमारा मेल आईडी का टाइप करो. Okay. मोबाइल का ऐसे नहीं निकाल नहीं लिखा हुआ है. हाँ मानस
मैं लाइक कर सकूं.
हाँ मुझे व्हाट्सएप कर दीजिए. लास्ट में भी मुझसे प्रॉब्लम है. So I think the slides are on the way. We'll be sharing as soon as it comes to us. Mm, so by this time, we'll take the opinion of Professor Pani regarding a very important point which was raised regarding the HFNO and NIV. We know NIV and BiPAP are commonly used in the patients in different ICUs. Many don't have HFNO equipment, but the important issue uh, comes is the whether as Professor Rai has already shared. It is here. It is here. Right, download. Right, that one. So would like to know the opinion of. Share. Okay, share computer sound, optimize, share, share. Uh, so you are able to see, Dr. Manas, are you able to see the slides? Oh. And Dr. Manas?
Yes, sir.
Yeah, yeah. So it's changing.
Yes, sir. Yes, sir.
Yeah. So
Good
you can,
afternoon, everybody.
yeah, yeah. You can start
Yeah,
presenting it.
okay. Good morning. Good afternoon, sir. And good afternoon, Panambar sir and Sarani madam. And good afternoon to all my colleagues or juniors. I am presenting one case, and really in every case their scenario is different. And in this case, I have used itolizumab and the importance of tone ventilation. All of you know how to use and how it is affect patient to patient and when to use. And this is my opinion, and for that sake, I am presenting this case. Next. This is the patient Mr. Alok Kumar Naik, a 30 years old male, and admitted to our hospital on 25th. And next. He is a very young patient and fever and cough for 5 days and complaining of chest congestion. And at the time of presentation, he was alert, conscious, and cooperative oriented. But his saturation was 87% and tachypnea. This is the presentation during presentation. Temperature febrile and pulse rate around 124. Blood pressure was 110/70. This is the time of presentation. And then patient was admitted in ICU as his oxygen requirement increased to 80 liters per minute to NRBM. And normal as protocol treatment, zone, remdesivir, and Dexona OD, and all sort of thing, and enoxaparin was started. And with this treatment and all the investigation, as per, we have made some protocol here to streamline the things, and we have sent all the investigation. Then his oxygen. Next slide. On day 2, his oxygen requirement increased, and his saturation was 91% with 12 liters of oxygen to NRBM, and pulse rate decreased to 101. And the important lab findings are PLC was 5,100, CRP was 79, and IL6 was 87.98, and safety severity score was 22. Then the same treatment was continued, and this is the day 2 X-ray along with day 2 X-ray showing this picture. Next. On day 3, his oxygen requirement increased further, and really, then we thought then we put him on NIV, and his work of breathing also increased, and oxygen requirement increased, and the PO2 FiO2 was decreased. That's why we put him on NIV. Next. Then patient deteriorated further and put on NIV. saturation was with 5 to 50%, the saturation was 91, and this was that day. And the lab parameters is increased. CRP was 107 and IL6 was 105, and the PO2 FI2 ratio was 102. And at that point of time, at the evening, his oxygen requirement increased further. The FI2 oxygen, we have to increase the FI2 to 90%. And the respiratory rate was support was increased. But in spite of all the things, I thought we can avoid, by introducing Itolizumab, maybe we can avoid the invasive ventilation. In some cases, we see after giving the Itolizumab or Tocilizumab, we can avoid NIV. Clear cut, it is saying NIV failure was impending NIV failure. Still then I persisted with NIV. I thought we'll continue with NIV because the NIV failure clear cut indication that as the tidal volume is generating around 10 to 12 ml per kg, 14 ml per kg body weight, and the respiratory rate was around 35, 36 at that time. Then I thought he will see, and my resident said, sir, this is the finding. And I hold on, at least one day we'll see. Then, but next slide. Next slide. And the patient deteriorated at night around 9 p.m. My resident said the saturation is 90% with NIV, FI is 100%, and he's generating us lots of volume. That's why I said, please intubate the patient. And at that time, the PO2 ABG was done, and the PO2 FI2 ratio was 76. And I said, intubate the patient and put him in proning. Then during the proning, the FI2 was initially set at 100% peak of 12 and tidal volume 420, respiratory rate around 24. And the dexamethasone initially at that time, and I thought this is a cytokine storm, it was already given, and the dexamethasone dose has increased. As I said, the discussion, and we'll discuss further about this steroid, high dose steroid, double dose of steroid of dexamethasone, then that will be a discussion part. But in that scenario, we have introduced Itolizumab. Along with that, we give dexamethasone body dose. Next. And the patient on ventilated volume mode with 16 hours of proning. The next day, the oxygen PO2 FI2 ratio still remain low, and we continued with plan for prone ventilation another 16 hours of proning, and we continued with that treatment. Next. Next. On day 7, his oxygen saturation in our FI2 70%, his oxygen saturation increased to 99, and PO2 FI2 ratio increased to 147. And all the vitals, all the parameters are within normal limit, and CRP reduced from 120 on 14 to 34. And the same treatment was continued for that patient. Next. And day 8, his oxygen PO2 FI2 ratio is continued with like that only 140, 130 around. We continued with that prone ventilation. Next. Next. Day 9, he was on ventilator, and PO2 FI2 ratio increased to 175. Then the CRP is coming down, and we have reduced that dexamethasone dose to OD dose. And we continue with supine ventilation of that because the oxygen requirement has increased and PO2 FI2 ratio increased. And on day 10 also, is maintaining that, and CRP is reduced to 3.6. And we have changed in September June was stopped as PO2 FI2 decreased, and I thought the count was normal, but we have accelerated to September Kajua count. Next. 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 Next on day 11, as the PO2 FI2 ratio increased, and I was planning to extubate that patient on day 11, but I saw it, he was on CPAP, but his blood pressure is decreased to 80/40 with heart rate of 124. on day 11. Then I changed the culture, ET culture sensitivity and blood culture, and steroid changed to Primac 56 only, and Actamaz was step, and meropenem. I changed to antibiotic escalated to meropenem and teicoplanin. As the hypotension sets in, then I have already etrusumab is given. That's why I changed to antibiotic. But he responded well to that antibiotic, and next day he was on CPAP and with maintaining saturation that and pure was around say 160, and the CRP is increased to 150, and PLC count next day PLC count was 17,000. Already I have escalated that antibiotics. So I continued with that as the hemodynamic stability is coming and NORAD support was coming down. And only he was on CPAP intermittent control mode and continued with that antibiotic. So next. On day 13, he was on CPAP and PO2 PLC come down and the hemodynamic stability sets in and the PO2 FI2 increased to 250. And the same antibiotic which was continuing, we are continue with that antibiotic only. Next. On the day 13, the X-ray was like this only. You saw the first day, second day X-ray. This is the day 13. And next. So next. On day 14, the patient was on CPAP and the count was in decreasing trend and the oxygen PO2 FI2 ratio increased to 232. Then I thought it is the time to extubate the patient, and the next day, the next slide. And the day 15 patient was on CPAP and his PO2 FI2 increased further and patient is stable with no NORAD support and the count was on normal side and all the parameters are normal and patient was extubated and put on NRBM and only adrenal nebulizer was given due to some cord edema like that. Then next. And that's 16, the patient on NRBM and oxygen SpO2 was 96% with 5 liter of oxygen. Then NRB normal mark patient put on normal mark and the same antibiotic continued. And I stressed on some parenteral and nutrition only. I added some amino acid to that patient because already day 15 and the nutrition I thought is not adequate. That's why I started some amino acid supplementation. Next. Is the day 16 next day. Next. Patient then on day 17, patient was on home air and the patient rice tube was removed and patient was on normal diet and then patient shifted to ward. The ABG and oxygen requirement also decreased. Patient shifted to ward. This is the X-ray of that patient on day 17 in ward and patient is being discharged for them. This completes my presentation and really 2 things I have to say in the right. As his oxygen requirement increased and the inflammatory markers has increased and that the day 3 at that evening. That's why we have I plan to give etolizumab and I could have prevented some NIV to invasive ventilation, but I could not prevent. For the effect was then with pruning and all those things, this patient came out of ventilator, invasive ventilation, but I landed in Solheim and he secondary infection and was he goes to shock and we have to escalate the antibiotic. Just that thing, that patient recovered and responds to antibiotic very well, and we are able to extubate that patient and shift it to and discharge that patient. Okay. Hello.
Thank you, Dr. Manas. That was a very interesting case. A young boy who required oxygen and oxygen requirement went on increasing. So timely you have put the patient on NIV and intubated, and also given interleukin 6 inhibitors, and weaned the patient and took to the ward. Very interesting case. We'll listen to our experts on the case. Professor Banambar Rai, you comment on the case.
Manas, I just wanted to ask you, did you give tocilizumab or any other prototype on the day 4 or so?
This is day 3. I have given him day 3. I thought, but day 3, day 4 I have used really.
No,
Initially,
did
his
you?
option.
This is because the CRP went up to 105, and IL-6 also went beyond 100 or so. Is that what was the provocation to give it on day 3?
No, that is no. That the provocation was oxygen requirement is increasing gradually. Really, that day suddenly it will from 12 it got to I have to put an NIV from NIV to initially he was maintaining in the my in my round. It was on NIV with 60% FI2, but in the evening his oxygen requirement has increased. I have to increase that FI2 to 90%. The
No,
till
that
then we have
happens
to
quite a number of
clinically.
cases. But normally, when you give tocilizumab, it is within 24 hours of deterioration or maximum 48 hours, not beyond certainly. That has not been recommended by any study.
No, sir. In recommended, he is requiring a lot for 6 to 8 liters of oxygen, and the gradually he is increasing. Really, I hold on till at least this is government and COVID care center. Then we have to judiciously we have to use, and when the oxygen requirement on day 3, when the oxygen requirement is increased and the inflammatory marker is increasing, it's clear cut it is on day 3. Even it is day 3, but in some studies, in delayed cytokine storm was happening, and they are also giving in delayed in 7 to 8 days. Also, they are giving the IL-6 inhibitor. This is the some recommendation and some giving. So delayed there is cytokine storm and the oxygen requirement and current markers can goes up to, and you can give that time also. Not just 24-48 hours. This is a guideline, but in those
First
cases,
of all, this is not a drug which is used by most of our experts anywhere in the earth. Okay, and it is only conditional and very clearly stated that if at all you want to use it within 24 hours. Don't use it even 48 hours maximum grace period has been given to you, but not certainly beyond 48 hours.
48 hours.
Right?
No. You are saying 48 hours from where to 48 hours? That is my point. From
Not,
where to 48 hours?
48 hours, but 48 hours of
48 hours.
deterioration.
From
right?
Where
The patient has taken a turn, right? For the worse, absolutely. And within 24 hours, you give it, right? And again, results are not absolutely, and our experience is only one case. But those who have done it, they also do not find any favorable results, right? So therefore, 2 cases, 3 cases, there is an article in the last Indian journal. They have done some 6 cases and they have found some results, right? But these are anecdotal observational studies. They are not absolutely randomized control trials. So therefore, I'm not sure whether tocilizumab actually does the job. Tocilizumab, we look at the IL-6, we don't look at the other interleukins, isn't it? IL-6 is only one of the many that may be happening. And IL-6 can go up by any other inflammatory process as well, right? Even if you do not give tocilizumab, it can still come down. Okay. So I'm not very sure.
I actually agree with you, Manas and Dr. Rai, on different points. With Manas, I agree. Actually, the last article on the trial on tocilizumab, if you say, I can't recollect the name of the trial actually. There was a good discussion on that. And it has been initially the company itself actually, put it into vein saying that it's probably toci is not useful. But when this couple of studies, last one and the meta-analysis, did show that when this Tosi drug is used within 24 of the acute deterioration, I think which Manish is pointing out that the patient was on 5 to or 6 to 8 liter of oxygen or maybe for 50% and then went up to 90%. Within that 24 hours of that deterioration, not that the point where the patient got
Yeah,
admitted.
that is my point. Yeah,
According to that,
that is
I
I
can't
want to
remember
say.
the name of the trial actually. So according to that, actually that trial recommends using Tosi within 24 hours and when other organ functions are still maintained. So that is a right indication to go by the trial. But also I agree with Dr. Rai that Tosi in bigger trials in all over the world, it has not made any, no, definitely no mortality benefit. Only this trial did show some few less ventilator-free days. The last trial, which recommended its use within 24 hours of acute deterioration, that did show few days of less ventilator days. That's all, but no mortality benefit. And always the complication remains about the secondary sepsis, which you also faced. And
Yeah,
actually,
yeah.
first wave also, when it was a fancy drug, and we were thinking we had very few doses reserved at the government level. And I think we also, corresponded to get it for a few doctors. Myself, I've also contacted. That time also, always my fear was about secondary sepsis. And that is why probably, most of us have gradually phased off and have stopped using it. But as you said, within 24 hours, that trial gives a recommendation actually, the last one.
Then you somewhere did you say CPAP 30/6? Is that what is 30 is the pressure support and 6 is the end expiratory pressure, or
No, PEEP is 6. PEEP was 6.
PEEP was
PEEP was 6.
no 30/6, that slide showed. 30/6 means what?
30%, 30%.
F5. That was right.
So 0.3 FiO2.
Yeah.
0.3 FiO2
Yes.
and 6 centimeter end expiratory.
Yes.
I see. Okay.
I think it's a good case. Responded.
It is a very good case actually, in the sense that within 10 days or 12 days, the patient was extubated and came out. I think that is something which is very rarely seen with such patients.
Yeah.
The other
We
thing
do
I
not.
mention is about the role of biomarkers. I think biomarkers are being overdone, especially in admitted patients and in appropriate settings. Actually, apart from D-dimer and CRP, the other ones like IL-6, ferritin, LDH have no therapeutic role whatsoever, neither in prognostication. So at least, I mean, if you're keen on doing some biomarkers, at least the best is CRP and D-dimer. But then again, the CRP alone as a number also should not guide therapy. It is the clinical status of the patient, like the oxygen requirement, the acuity with which the patient, or the rapidity with which the patient deteriorates. These are the clinical assessment criteria which should guide therapy. You used a higher dose of steroid, I understand, and I also actually have been using these high steroids in the second wave, so I can understand that. But as such, other than that, you can see the trend for as a marker of response to therapy, but it's not necessary all the time. Using IL-6 and as a criteria for using TOSI or otherwise also, it is not helpful because it's not been not tested. Ferritin, LDH, etc. I think we should stop doing it actually. In the first two, it was okay. We are started researching. You were not didn't have many clues, but it is not. These are not necessary.
But Sarmili, the ICMR has not revised its recommendations. ICMR, for whatever we have understood, I think ICMR has given an indication that you must do the biomarkers every 3 days or 4 days. That is what, whether or not the patient is deteriorating. That's what, whether you will take it or you don't take it. But ICMR and All India Institute of Medical Sciences combinedly, they have actually given this recommendation, which I also feel that it should not be binding on us, right? Why should I do the biomarkers every 3 days? I don't understand, because if the biomarkers I do, I have got to act. Yesterday, somebody showed me that all her biomarkers are fine except IL-6, which is more than 5,000. Do I have to act? She has an oxygen saturation of 98% on air, and she doesn't have any complaints. She had fever, but fever was not there for 24 hours. Biomarkers, if you do 5,000 IL-6, I think anybody will think that no, you give tocilizumab. It is not right. I think if you are doing it, you will be forced to act also. But better is that you shouldn't do it unless the clinical condition deteriorates.
I think that the guidelines are there to guide, so we can always, the clinicians can take.
Yes, but they are very particular, and they, the same way they say that it is tocilizumab, remdesivir. These are all the drugs which are not the routine drugs that one should be using it, right? So
maybe revising soon. I think many societies would have given the recommendations, and maybe its pipeline for the revision might be in pipeline soon.
Yeah. Actually, CRP being such a affordable investigation is more informative than these LDH, ferritin, and a series of markers that you do every 2 days, 3 days in the issues. So for poor man and even in a common place, you can have a CRP and roughly you can assess the inflammation, degree of inflammation. So rightly told, I think Manas has done a good work by supporting the patient, taking the risk of delivering itolizumab and also manage the following sepsis very successfully and extubated the patient. Professor Pani, you would like to say something on this? Nivita ma'am? Professor Pani, Nivita Pani, yeah. Ma'am will like to say something on Dr. Manas' case. You're muted, ma'am. Please unmute. Yeah. Madam, I'm doing that. Yeah. Okay. Ma'am, please unmute. Please unmute, ma'am. You are enabled. You can unmute, ma'am. Ma'am will say something regarding the second case.
Jayant, am I audible?
Yes, you are audible, ma'am.
Jayant, I think I'm not audible most probably.
No, you are audible. You are audible, ma'am.
Because I'm not able to listen your voice, Jayant.
No. I think you are traveling, but you are audible to us. You can quickly say your comment on the second case so that we can move further. You are unable to see. Unable
No,
to.
I'm not able to hear anything.
Oh. You have to check your audio. Anyway, ma'am is disconnected because she is traveling. So we'll take
about, apart from the biomarkers, about the CT scan. I think is the right forum also. We have been discussing it. I think CT scan is being overdone in the community. Now patients are getting CT scan, affordable patients. We are getting it done on the day 3, 4, 5, 7, even without any oxygen problems, and that is also actually adding up to the issue. I mean, request for more hospital admissions.
Many patients, they come with CT scan. Once they have a positive report, directly they go to CT scan center, and many are catching the infection from CT scan centers. They are going for a scan, getting the infection, and directly coming to Manas and getting admitted in hospital. So similar situation. So very horrible state of affairs. Even
and second thing is,
Yeah.
Second thing, sir, they are forcing us to do in government sector now. Why you are not doing? And all are influential people. Why you are not doing city tour? How many times I said it is not decide our treatment and treatment guideline and treatment modalities, but still then they are insisting. They will any influential people, they will call you, sir, please do city for that person, like that only, because these are the government hospital and government providing funding. Then
Yeah.
they are doing like that only. I am facing lots of problems for that. For
Yeah,
CT
yeah,
scan.
yeah. So they'll force you to give remdesivir and do a CT scan. These two things have gone to people. So we are next session we are doing it on a rational therapy of antivirals, especially the remdesivir, and maybe we'll add this issue. Should we do the biomarkers and the CT scan routinely, so frequently of the patients? That also, because we abuse more than getting the use of these tests and the biomarkers. So the final comment from Professor Rai before we end the session. We had two interesting cases from Apollo, and Ashwini and Dr. Sharmili and Dr. Manas has presented two interesting, unusual cases, and we have given a very good message to our audience. So, final comment, share, Professor Manambara.
Thank you, Jayanta. This is, I think, both the cases were quite very interesting from point of view of our daily practice is concerned. Those of us who are practicing outside Cuttack and Bhubaneswar, especially for those who are in the remotest periphery, if you have a ventilator, if you have the oxygen appliances and devices, you should actually be able to treat these patients there. Absolutely no problems at all. NIV, of course, one should be giving it if you have the ventilator. When to intubate, when to continue with NIV, I think purely it's a clinical decision. And if the patient is in respiratory distress, even while on NIV, and he has got a minute ventilation which is very, very high all the time. We have seen minute ventilation 47 liters. And imagine if a normal minute ventilation is 7 to 8 liters, and if a patient has got 40 liters of minute ventilation, obviously he will be doing it, prompting all his resources at command. And he must be doing it 8 liters to 40 liters 5 times. I always believe that somebody is doing a cross country race all the time, and such patients, if they have to stay for 24 hours or 48 hours, it is pretty late before you have taken a decision to intervene, intubate and ventilate. So it is better that you do it rather early, instead of allowing the patient to exhaust all his resources and then become tired and exhausted, lactate going up high, and something which, the outcome will be quite different. We all of us know that anybody who needs mechanical ventilation invasively, the results are not very good, because the world literature says the initial reports were that 88% mortality even in the United States, and we are no better. We also have about 20% success and 80% mortality, all of us, if you actually follow them up for a very, very long time. Some complication or the other, they may come out from the ventilation, but they might die because of the complications. So therefore, if you do it a little earlier than what you do normally, waiting on the NIV, I think you would be doing a lot of harm to these patients. This is something which I think Manas did it very well. I think he must have actually intubated pretty early, and then therefore the patient also came out early, because 10 days, 12 days, somebody who is extubated to remain, we saw the photograph. I think this is commendable, absolutely. I would agree that he has actually done a very good job. And Sarmili's case also with NIV, I think if you started off with 27th patient was admitted and she was discharged on the 8th of May, this is also commendable, because somebody who was needing so much of oxygen in the beginning came with 70% on air, because they must have given NIV, but I'm sure NIV on the way must have fallen off, or it must have been inefficient. So 70% it will be further less actually if patient is breathing air. And to be discharged on the 8th of May, I think it is a tremendous case. We normally don't get such cases improving so fast. So therefore, I think this is certainly an encouraging session by both of them, and they have done exceedingly well. This is something which I'm sure the audience, which is not very many, I think total we have had about 21 or 22 members, but these 22 members I'm sure would have been educated at the end of this 1.25 hour, something which they will go back completely re-educated, re-experienced, and then would be able to utilize these concepts in their day-to-day practice. Thank you very much. And then next one, whenever you do, I'm sure Jayanta would come out with certain beauties in the next session as well. We can have much more discussion on this. Thank you very much.
Thank you, sir. Professor Pani, are you able to listen us?
Yes. Actually, in that Jobra area, the connection got cut actually.
Well, so
now both the cases are really, John, very interesting cases also. And the viewers who are there, who has listened to these cases, is definitely helpful a lot. And they have done the very good job. And definitely in our scenario, John, yourself, myself, we are seeing, even if we are managing also, we are seeing all the catastrophes also we are seeing. So I hope if you treat the cases in the right time and right moment, definitely we can do something justice for the patient. That is my view. And certain patient, they flare up so badly also, we are helpless to do anything.
Thank you, ma'am. So it's a very successful webinar. I must thank Professor Manambar Rai, Professor Nimita Pani for the valuable time they have given, and Dr. Sharmili Shinna, Dr. Manas Naik for the interesting cases they have prepared. All are very occupied, very difficult to save life day in and day out, and from that taking time and presenting slides is really challenging. They're all facing the same problem. They have done that for the interest of the training, and there are less number of people who attended today, but this is already streaming in YouTube, and everybody who want to see the case discussions, they log in, and we see thousands of people. They take the advantage because it continues to stream in YouTube hereafter. So I thank Professor Rai, Professor Pani, Dr. Sharmili, Dr. Manas, and everyone, and the dean and principal, and the superintendent, and the capacity building team, health and family welfare, our SCS sir, MD, NHM ma'am, for encouraging this webinar. Again, next week we have Tuesday and Thursday on very interesting topics. Tuesday we'll have discussion on the misinformation of the investigations and the treatment modalities, which I have already told, including the markers, including the scans, and including the drugs like remdesivir and tocilizumab, which has been much demanded around because a layman has understood something of the treatment policy. We have demands from every end, and why don't you give this and why don't you do that? So thank you again. See you again next week, Tuesday and Thursday. And thank you everyone, especially Dr. Sharmili and Manas for interesting cases. Thank you.
Thank you, sir.